Welcome everybody to our sixth seminar on COVID. We are once again joined by five wonderful professors and experts. I don't think there's a better category of panelists anywhere in the country. It reminds me of when Frank Lloyd Wright was in trial many years ago. Frank Lloyd Wright, of course, was a very litigious man, was always involved in lawsuits. And he was sued once again by one of his clients and was in court in Chicago. And he was called to the witness box and was being cross-examined. And the hostile attorney from the other side said, "Mr. Wright, tell us who you are." And Frank Lloyd Wright thought for a minute and he said, "Well, I'm Frank Lloyd Wright, the world's greatest living architect." And then there was a hush over the courtroom. And a few days later, Frank Lloyd Wright ended up winning the trial. And one of his colleagues came up to him and said, Frank said, "Mr. Wright, I've got to tell you," I said, "congratulations on winning the trial, but I must say that we were all a little concerned when you said what you said." And Frank Lloyd Wright says, "Yes, I thought about it, but then I realized I was under oath." So tonight we are joined by Dr. Margarita Cancio, who is an infectious disease associates founder and managing partner. She's an affiliate professor of internal medicine at USF. And I want to thank Dr. Cancio personally because she was instrumental in getting several of my colleagues vaccinated back in the early days when it was so hard to get them. So thank you, Dr. Cancio. We have Dr. Douglas Holt, Health Officer for the Florida Department of Health. Hillsborough County is in charge of our health in this county. Professor of Medicine at USF in the Infectious Disease Group. We have Dr. Kami Kim, Professor of the College of Medicine Molecular Group, Director of the Division of Infectious Disease and International Medicine, Joint Professor of the Center for Global Health and the Infectious Disease College of Public Health. I had to look at my notes, I couldn't memorize all of that. And we have Dr. Charles Lockwood, and let me just up front say how grateful I am that Dr. Lockwood has given back to our community and participated with us. It's a wonderful thing and so important for our community. But he's the Vice President of USF Health, Dean of the USF Morsani School of Medicine, Professor of OBGYN and Public Health at USF. And then last but certainly not least, Dr. John Sinnott, a fellow native of Alabama with me, who always puts first on his list, scientist. I like that. Chairman of Internal Medicine at USF, Director of Florida Infectious Disease Institute, and the former Associate Dean of the USF International School of Medicine. So we've got a good number of excellent questions tonight. I want to just tell the audience that as we go forward, please, you can message me a good question. I'll be glad to work it in. So I'm going to run through these in fairly rapid fashion. I want to start with Dr. Cancio. Dr. Cancio, a week or two ago, 8 or 9 of the New York Yankees baseball team was infected and could not play. Can you tell us exactly what's going on with that because they were all vaccinated?
Well, the vaccine helps you not to get really sick and not to die, but you can still get infected if you have been vaccinated. There have been just like that case. There have been many others, and some individuals have gotten sicker. But it's not a total protection against getting infected. You just don't get as ill and certainly less likely to die.
So there's a trend nationally where they're not testing people who've been vaccinated. What's the point of testing someone who's been vaccinated?
If someone has the correct symptoms, and even though they may have been vaccinated, they should be tested. Mainly so that they don't, they're less likely to cause transmission, but they can still do so. And certainly that should be done. We also need to think of a lot of particular patients that may not have the ability to develop antibodies, even though they may have been vaccinated. Being an infectious disease physician, I take care of a lot of immunosuppressed patients. For example, the group of patients that have immunoglobulin deficiencies, we have a lot of IgG deficient patients, and those patients, they don't produce immunoglobulins, so they're not going to produce immunoglobulins against the vaccine. So we encourage the whole family, almost like being like a wall for them but those patients still have to be very careful. We encourage them to continue to be very careful. Another population that we worry a lot about is a population of transplant patients. After the first vaccine, only 17% of transplant patients develop antibodies. Even after the second vaccine, only 50 to 55% develop antibodies. So that population, we have to be very careful against it, and not assume that they're protected. And we have to still have that wall of people around them that should be able to get vaccinated and produce antibodies. Particularly the antimetabolites like Cellcept, Imuran, those drugs are particularly difficult with a vaccine, and they may not produce antibody. And there's a lot of patients out there with other diseases, such as simple as bad atopic dermatitis may be on Cellcept, and they may not be able to produce antibodies. So we have to, as physicians, we need to understand that patients, not all patients that get vaccinated are protected. That's one point. And number two, even if you are vaccinated and develop antibodies, you may still get infected. Hopefully you won't, but you will have less disease. And those immunosuppressed patients that may not be able to produce antibodies, as I just mentioned, the immunoglobulin deficient, the transplant patients, or those patients and specific drugs may benefit still from therapy like the monoclonal antibodies.
Very good. And I would imagine it'll be like hepatitis B, where some patients will require a third vaccination as well, perhaps, to build up antibodies. All right, Dr. Holt, I'd like to ask you, here's a question. How is Hillsborough doing? How about our cases, our deaths? How are we doing on vaccination? The Florida daily positivity rate is down to 4%. How is Hillsborough doing?
Yeah, our Hillsborough County, our rates are also trending down, but they are above both the state average and Pinellas County. We're just taking a little longer to get down to where they are. Our case rates are around 15 per 100,000, translates into about 250 cases a day. Our positivity rate is a little over 6.5%. But the good news is our admissions are dropping as we've seen across the state, as well as our deaths. The age, the transmission rates are continuing for all ages to go down. The highest are in our 35 to 44, 25 to 35-year-old, but notably different. The lowest is in the over 65. That's the most clearly distinguished age group that you can say is showing a much lower transmission rate than anyone else.
Very good, very good. Dr. Kim, Eric Topol has termed them scariants. Could you tell us about variants and mutations and double mutations? And are they in Hillsborough County?
So, there's a lot of mutations in viruses. So for people who don't know about viruses change their nucleic acids, and then they make what are called mutants or variants. And it's sort of not completely accurate to say double variants and things like that. There are a lot of different flavors of virus that are out there that are labeled variants, and they have different degrees of danger and transmissibility. They tend to be have a nomenclature that's based on virology, so it's B117, which is sort of what group it came from, also called the UK variant. So that variant was the one that was like the first famous one. That seems to be the predominant variant here in Florida. It seems to be more transmissible, probably because it's more infectious. It is associated with greater death rate and things like that. So obviously that makes us concerned. The good thing about that variant, even though it is more transmissible and more of concern, both the vaccine and the monoclonal antibodies seem to work against this variant. So this is where, getting back to what Dr. Cancio has, we have to be very careful, we have to be vigilant, but the treatments that we've developed for management of that particular variant seems to be working. Obviously, because we know that there are variants out there that are a little bit less neutralized by either the monoclonal antibodies or the vaccine, we're concerned. So there's the variants that came from South Africa, and also the P1 variant, which is sort of increasing in prevalence, that came from Brazil. And those are definitely, as I said, the antibodies elicited by the vaccine and even the monoclonal antibodies may not work quite as well. But that doesn't mean that they don't work. You know, we're monitoring it very closely. And it's not particularly surprising, but this is why many of us, despite the vaccine and treatments being available, still are being cautious about opening up and advising people to, you know, use some judgment about what risk they're tolerating and things like that. There will be variants. That was to be expected. We're monitoring it very, very closely. And Florida, because people love to come here, you know, we have more from all over the world.
Very good. Thank you. Thank you very much. Dr. Lockwood, as you know, the CDC recently came out with a directive about the wearing of masks, who should wear masks, and that sort of thing. Would you comment on the mask wearing and who should wear a mask and who shouldn't?
Well, you know, I think that the folks in at least Hillsborough County are voting with their feet, because there's very little mask wearing. I was at the hockey game last week, and no one was wearing their mask, essentially. And that was
How about the goalie? Was the goalie wearing one?
No, apparently not. I actually have not gone to a game yet. They've won. They should pay me not to go to Lightning games. So, you know, it's an interesting phenomenon. If you look at the seroprevalence of the virus in Florida, at least the CDC's report on it, using nucleocapsid antibodies, so it's not picking up the vaccine. In March, we were at about 21%. So that was after the big spike in January. So that's probably the best estimate of the prevalence of past infections, 21%. If you look at the percent of folks that have been vaccinated, we haven't quite got to 50%. But if you assume that half the folks that have been infected have been vaccinated, which is about the same rate as the general population, it means that overall for the state, about 58% of residents of Florida are likely immune, either because they were infected or because they've been vaccinated, or both. If you look at the distribution of vaccinations, they mostly are in older folks. So 68% of Floridians over 12 are likely immune. And if you look at the over 65 group, where there's an 85% prevalence of vaccination, then they're over 90% are immune. So clearly, if you're if you stick to an environment like the villages, where everybody's over 65, you're probably home free. But it does suggest that the pandemic is shifting, shape-shifting into, as Doug already pointed out, a much younger population. They're less likely to be sick, frankly, much less likely to even be detected, because they're more likely to be asymptomatic. So at some point, as a society, we're gonna have to say that folks are gonna have to accept responsibility for themselves. The vaccine's readily available. Everybody should take advantage of it. There's almost no one in the United States that shouldn't be vaccinated. But we do have populations that will remain at risk. The transplant populations that Dr. Cancio just talked about, particularly vulnerable, and they will need to continue to wear masks and to socially distance and to have that shield of folks that have been vaccinated and probably mask wearing around them. But for the bulk of people that have been vaccinated, and for those that are at very low risk, I'm not sure anymore where we stand with masks. Clearly not needed in a outdoor setting, according to the CDC. Probably not needed if you're vaccinated, if you're in the Emily Arena. So they may not, the people voting with their feet may be correct. I think if you haven't been vaccinated, first of all, you should be, but if you're going to be in a indoor environment, you should wear a mask. They're not gonna, but they should.
Very good, very good. I think it's still going to be a personal preference type thing, and there's no way to know who's vaccinated and who isn't, so it's really hard to go forward. Dr. Sinnott, so I'd mentioned kudzu to you earlier. So there's some experiments that have gone wrong, probably the most famous one being Dr. Frankenstein. But, you know, in Georgia, kudzu was brought in as something to feed livestock and has taken over the state of Georgia. And of course, in Florida, love bugs supposedly were in a University of Florida experiment gone wrong. So I'm going to ask you, as I'm sure I'm going to, about did this virus escape from the Wuhan lab, and what is the likelihood of that happening? And if so, what are the repercussions?
Well, you've asked me, I think, a loaded question. If you had asked me a year ago, I would have said, absolutely, this was natural evolution. It was very typical of a coronavirus to go from a bat to an intermediate host to a human. For instance, with SARS-1, we found the palm civet cat as the intermediate within 5 months. With the Middle Eastern respiratory virus, another coronavirus, within 3 months, we found the specific species of camel. But now, well into the pandemic, we don't have an intermediate host, and we don't have any evidence of this virus in nature. And literally in the past 3 days, my thinking has taken a turn about 180 degrees. And I'm now really looking closely at the idea of not a deliberate release, but an escape from a laboratory of things very circumstantial, I think, suggests this as a possibility. Number one, something I didn't know, although I have visited that laboratory, is that they were doing gain of function studies. And these are studies where you attempt to make an organism more virulent so that you know what vaccine to make. It's routinely done with influenza. It has been done with smallpox. I find this profoundly concerning. The second thing is that there was a clear trail with SARS-1. With SARS-1, there were issues in Tianjin and then Beijing and then Singapore, but everything started in Wuhan. And there weren't other places. There aren't antibodies other places. And finally, in 2012, in an abandoned mine, 4 of 6 workers became critically ill in Wuhan province with a new coronavirus. And of all things, that coronavirus seems to be the closest relative to what we're seeing now. I think that it spurred me to read the entire World Health Organization report, and I find some omissions there. There's no documentation in the logs of what level of containment was used in the lab. That lab has everything from a simple BSL-1 biocontainment safety level 1 that you'd use for staph germs to BSL-4 for Ebola. But apparently some work was done with these dangerous viruses in a BSL-2 facility, which means the researchers would actually wear their street clothes into the lab where this was being done. So I think we need to revisit this issue. I realize it's extremely controversial. It's known that bat viruses normally don't infect humans directly. There has to be an intermediate. The idea that this mine in Wuhan did contain bat guano that made people very sick have made me re-examine this. And I'm looking closely at it to try to formulate in my mind which side to fall on.
Right. I mean, it's an interesting thing. I know that there was also something where 3 scientists in late 19 became quite ill who worked in that lab and were hospitalized with symptoms that looked a lot like COVID symptoms. So that's brand new as well. You know, it's, I guess when you look at, it used to be said in Washington, when something bad is going on in Washington, and you have to decide, is it some evil, brilliant, clever scheme, or is it incompetence? Go with incompetence. So I'm going to go with incompetence in that lab. That seems the most likely. All right, Dr. Cancio, you're an expert on travel, and I'd like for you to comment on traveling during this time of COVID. Where can folks go? And do you believe in vaccine passports? And when I was in the Baltic a couple of years ago, I noticed there were 2 other groups, one from China and one from South Korea, and they were both wearing masks, interestingly. So that was long before this pandemic. So what's your recommendation for travel?
Well, if you travel throughout Southeast Asia, you'll find people wearing masks all the time. And that's a very common sight, whether it's anywhere in Southeast Asia, basically, from Japan to China to Singapore to anywhere else. So that is a very common thing. And I think that we all should use, whenever there's anything, the flu or we feel sick or anything else, using masks has to become a more common fashion, put it that way, after what we have gone through with COVID. But when it comes to travel, anywhere where there's bigger spaces is the best idea. I mean, we definitely are safe in the outside, and doing family trips with whether it's camping or going to the beach or doing things like that, that's wonderful. But that's not enough. People are tired of not traveling. So you have to really look at what the country you're going to, if that's where you're going. Within the US, there are not that many limitations. Unlike the state of Florida doesn't have any limitations, doesn't have any requirements. So anybody can come to the state of Florida and without any type of concerns. But if you're going to go somewhere else, you may want to be careful. And still, there's a lot of requirements in Europe, as everybody knows, but definitely don't travel anywhere without checking for the requirements. Still favoring outside activities over inside activities. For other things that for travel, of course, cars are better, but airplanes are becoming more common, and that's fine. And you should wear a mask. It still is a requirement to wear a mask, even if you have been vaccinated. That is remains a requirement in airplanes. And then the question about cruises and things of that nature, my guess is, and it's all over the news, is that they're going to ask for people to be vaccinated. That's a very reasonable thing. It's very reasonable to ask for the people that are going to be on a cruise or in close quarters, and cruises is to ask for them to be vaccinated. And if you want to be part of that, then you should be. And these are private corporations. They have the right to ask for that. Obviously, the government has decided not to make any mandates, but the truth of the matter is that we can even ask somebody whether they're vaccinated. Asking somebody, have you been vaccinated, is not a HIPAA violation. That is not considered to be a HIPAA violation. And private entities have the right to ask somebody, I want you to be vaccinated if you want to work here. So cruise lines will probably require vaccination, some proof of vaccination. You have airlines like United trying to do some rewards for people that actually admit that they're vaccinated and they prove it. So in terms of travel, anything that has to do with outside activities is safer. Vaccination is good. Planes are okay now, but wear your mask. And probably if you want to go on a cruise, you're going to need to be vaccinated. And if you're going to leave the US, make sure you check what the requirements are, because every country is a little different right now. I hope that answered your question.
That's very helpful. Thank you very much. Dr. Holt, you know, we're sort of reaching a tipping point now where we have enough vaccine. And I was just doing a little survey among my patients the last few weeks. And there's a couple of groups of mine that are vaccine resistant. Often they are people who are extreme right wing. They are blinded. Both groups aren't called, they're blind ideology. In other words, making a lot so some states are having a lot of. New York State just recently is offering scholarships. What can we do to get our people vaccinated, Dr. Holt?
Well, I think you've touched on quite a bit of the challenges. It is, you know, the people have tried to educate. I think I would paraphrase. I think Dr. Sinnott told me once that for believers, there's no information is necessary. For the non-believers, there is never enough information. They'll not change their mind. So what we try to do is respect their opinions, educate, understand. We in the public health matter, what we're trying to do is overcome the barriers that people who want to be vaccinated so they can be vaccinated. So we're doing everything we can to put it literally on their doorstep, going to work, going to on the jobs. I think, as you've mentioned, there's an ideological resistance to just being told right now. And there's not, I think, much that I have found that is effective. And it has become a movement across the nation that I think is going to have a legacy effect right now. Some of the combination of lawsuits and other things that are being pushed to people to attack their freedoms, the determination of the couched it as a liberty that's being denied them, and that's that is a conversation that I don't have a good answer for.
Very good. Thank you very much. Dr. Kim, can you speak about vaccine reactions? It's really one of the rare times in a doctor's career where his patients complain if they don't have a side effect. They're scared they didn't get enough vaccine. Could you comment on that?
Well, I mean, I think, so it depends on obviously which vaccine. The Pfizer and Moderna, these are the mRNA vaccines, and they seem to have a slightly greater frequency of standard vaccine type side effects. So fevers, joint pains, generally feeling poorly and things like that. And that some people think, oh, well, it's great, I have a reaction. Some people are worried if they don't have a reaction. I think the bottom line for those vaccines is, we've now given them to hundreds of millions of people, and we haven't really run across things that make us concerned and that the safety profile isn't very, very favorable. I think there are some concerns, obviously, with AstraZeneca and the Janssen vaccines, that there seems to be this vaccine-associated thrombocytopenia and clotting. It's not yet clear whether that's something related to that adenovirus vector, since we haven't really seen that with the mRNA vaccines. That, of course, is also extremely, extremely rare, but much more concerning because some people have lost their lives and become very, very ill. I think, though, the bottom line is, if there's any concern, for people to be, heads up and contact their primary care provider and things like that. But I think overall, I think people were a little worried about the vaccines, but they've proven actually to be extremely, extremely safe.
And I think a lot of people are looking at association versus causation. If you give 100 million people something, there's going to be some Guillain-Barrés and a lot, and I was looking at that breakdown, there were about as many people with Guillain-Barré who didn't receive the vaccine. So it's an interesting thing. So I appreciate that. All right, Dr. Lockwood, here's one. What do you think about the Olympics in Tokyo? You think it's a go or not? And what do you think it should be done?
Well, I think that all the athletes and all the trainers and personnel at the Olympics ought to be vaccinated. That at least protects them. I think that Japanese may want to consider a vaccine passport for anybody going into the Olympics. I think this may be the one setting where I would be insistent on masks for vaccinated folks watching the events, just because they're going to be scattered to the four winds and they're going to go all over the world, and you don't want them spreading some new variant, so forth. But I think if they did those things, all the personnel, all the athletes were vaccinated, and hopefully all of the folks that attend the events were vaccinated. I think it'd probably be very safe Olympics. Now, Japanese are having problems vaccinating their own folks.
Mm-hmm.
So they've got to get their act together. It's interesting how well they did early in the events. They were great with testing, mask wearing, contact tracing. They had a very low incidence of infection. And now when they're basically in the ninth inning and they suddenly gave up 30 runs. So, it's really quite unfortunate. And I think the solution is, vaccination.
I think they're only at about 20% in Japan. It's not a big number. So interesting. Thank you very much. Okay, Dr. Sinnott. So basically, one of my patients is a veterinarian, and he was trying to convince some of his rural folks. He's up in Dade City, and they were concerned that when you got the vaccine, you were getting chipped. So as a veterinarian, he's got a chip reader. So he actually would go out to the cars as people were bringing their dogs in, and he would take his chip reader. He said, I was vaccinated. Here's my chip reader, no chip. So that's an interesting thing. But there was something else out there that was asking about, can SARS integrate its DNA into the human genome? And I think people got confused between the vaccine and the virus, but could you comment, can a virus incorporate itself into the human genome?
I think the primary rule of genetics, and my fellow scientists I'm sure will weigh in, but that DNA goes to RNA and RNA protein. To go backwards would require reverse transcriptase like HIV has. This virus does not have that. This virus would not integrate into the genome. It just does not have that capability. I would reassure patients about that. But I would like to make what I think is a very important comment about masks. This year, 32,000 lives were saved because we had no influenza. As a matter of fact, on the average each year, 200 children under the age of 6 die of influenza. This year, it was one. So masks are not just for COVID. They're very effective at preventing the spread of influenza. And I think we need to broaden our discussion away from COVID and to the social responsibility of people to not spread influenza virus as well. And finally, I really want to applaud the man for using the chip reader. I think that was a great idea. I think I'm going to simply label one of my thermometers chip reader and aim it at people.
Well, your point's a good point about masking, but I've been told by several people that I look good in a mask. Dr. I wanted to ask Dr. Cancio about long haulers. Can you tell us about long haulers and how things are going? I think that speaks to one thing, and that is a lot of my younger patients who don't want to get vaccinated say, well, my chance of dying is 1 in 50,000 or 1 in 30,000, but we don't know what their chance of having residual is, do we?
Yeah, and it happens at any age. You cannot predict who is going to have long-term effects and how long, and it's not correlating really with the disease that they had. Matter of fact, there are a lot of patients that have had not that bad of a disease. Some of we have seen in the post-COVID world, we have seen a lot of patients that did not get hospitalized, that did not get that sick, but they just not feeling back to normal. And they almost get like a chronic fatigue-like syndrome. They have a lot of muscle aches, they can't sleep, they have significant fatigue, they can't think, they have this brain fog that they talk about it. So they have a lot of non-specific symptoms, and you can check labs and they're all okay. I mean, there are some specific things like some patients have myocarditis and some patients have pericarditis, and some of those get better with time, and that's fine. But there's this non-specific group that gets a chronic fatigue-like syndrome, which has this brain fog. They have significant fatigue. I mean, they tell you, I used to do X, Y, and Z, and now I cannot even get through a whole day of work. And then you have somebody like I follow, a scientist, and that having a really hard time doing her job. And this is somebody that I've known for many years. She's not making it up, guys. Okay, so and things like that, and then the muscle aches and almost like an arthritic condition. So, and it doesn't seem to get better. There have been a couple of patients that I have seen and have that they have gotten better with the vaccines. But then there's all the ones that think that they have gotten worse with the vaccine. So you don't really know, even though we encouraged all of them to get the vaccine because it probably in general is going to be beneficial. And we do tell everybody to get the vaccine, whether they have had when they have had COVID before. But it is an ongoing problem. And I think that we're going to need time to see how many of these patients get better, what percentage is not functional. And this idea that this disease does not affect young people, it is crazy. It is absolutely crazy. And I think that Dr. Kim and I that are in Take Call are seeing those patients at Tampa General. It is right now is affecting the 20s, the 30s, and the early 40s. And they're getting as sick as everybody else, and they're requiring ventilators just like everybody else. And we should not underestimate the ability of this virus to make people really sick. And being young is not a reason to just think, oh, I can get it and I'll be fine. You may get sick, you may get really sick, you may not die, but you may get really, really sick. And number two, you may have very few symptoms, but your life may be changed forever, or at least for quite a while. Right now we know a year, but who knows how long it would be. Time will tell us.
Thank you very much. Dr. Holt, it's interesting, you might want to get a slogan out there that says, get the vaccine or get the infection, because really this is probably going to be around with us for a long, long time. And we still give polio vaccines because Afghanistan and Pakistan have not eradicated it. But Dr. Holt, I wanted to ask you about, where do you see our school system going in Hillsborough? What are your recommendations? What modifications have they made?
Well, I mean, I think we should give credit to the leadership at our school. We really, you can see the impact that they've had. We really didn't see transmission, super spreader events in schools. All the kids that we looked at very closely, almost all of them were getting them from extracurricular. And now with time, as we've mentioned, that they're going to be the least vaccinated group. So you're going to have kids that are going to get infected and they're going to come into school and you're going to see transmission. So strongly with our parents, we're working with them to get vaccinated because that's how you break that chain. That's how you continue to get the success that they've had. We have something that is simpler, more effective, and that's the vaccine. There will not be any mask mandates. There will not going to be any, we're back in school. I don't see anything that's going to change that. So it's up to us and our parents to get our children safe.
Well, hopefully, if you want more of something, you reduce the friction and you increase access. So are schools going to offer vaccines? Maybe have a school nurse giving vaccines?
Yeah, we've already got some working for this summer, as early as in a couple of weeks. Many of the parents, talking with them, they really didn't want to get their kids vaccinated as they're going into testing and exam weeks and things like that. I expect we'll see an initial surge. The estimates are you're going to see 25 to 30% take on, in early adopters, if you will. And then we're pushing very heavily or educating that, not only do you protect yourself and others, the inconvenience of having disruptions, of perhaps having to be excluded. If you're vaccinated and you're around somebody who was infected, you just come on to school, you play your sports, so really trying to let kids and parents understand that that's really their ticket to get back to normal.
Excellent. Thank you. Dr. Brad Foraker chimed in saying that the vaccination rate in Japan was only 8%. So that's awfully low. Dr. Kim, I'd like for you to take us through a couple of scenarios. So you've got your doctor, he's in the office, he gets a phone or she gets a phone call, patient's just tested positive for COVID. Could you take us through the next steps on what to do with that patient? And then if there's any treatment required for the outpatient, what cues would you have to treat them? And then also tell us, what the current treatment in the hospital is. And then finally, there've been a couple of things about prevention with ivermectin and those things. So if you would just cover that from prevention to treatment. Thank you.
Okay, I'm going to start with the prevention part, the ivermectin. It's a widely available drug, and certainly in developing countries that's available because of its anti-parasitic effects. All the available evidence doesn't really suggest that it has a lot of effects, even though in many settings where it's available, obviously it's an approved drug, so people can prescribe it. So there isn't really much data that helps per se. And I think most of us would not recommend it. Obviously, there are studies ongoing. It is widely prescribed as hydroxychloroquine was, but I think at this point, most of us would not give it. But good data are good data. And, obviously if someone can, prove that, all of us would change our minds and prescribe it. Now, as far as somebody coming in with COVID with a positive test, this is where it's now pretty clear those monoclonal antibodies that are to the spike protein will decrease your period of viral shedding and make it much less likely for you to have severe disease, less likely to be hospitalized, things like that. That effect is particularly pronounced in medically vulnerable people, people who are, overweight, have cardiac disease. Dr. Cancio has been very, very proactive in getting all her transplant patients who come up with COVID treated with monoclonal antibody. And, there have been several studies, including our own study at TGH USF, that clearly shows that we prevent hospitalizations and serious disease. So I think for anyone who's medically vulnerable or has any intercurrent disease, I would probably figure out how to give them monoclonal antibodies. What's evolving and is not really certain is that the monoclonal antibodies seem to pretty much work in everybody. And so it's going to be much more now that they seem to be both safe and efficacious, whether people who are at lower risk, whether we would give it to them or not routinely. And I think that is a little bit, physician judgment and things like that. I think probably a lot of physicians, if it were me, I'd probably go get it just because of the concerns that Dr. Cancio brought up. Obviously, I'm not 25, so I'm a little older, so I'm in that risk group, but also because of potential concerns about long hauler syndrome and things like that, we all figure that if we can nip it in the bud, we're less likely to have complications. But I think that's a little bit controversial. And right now, these monoclonal antibodies are not available for inpatients. That may well change because there are some studies being done, and Regeneron in particular, I think they're one of the few companies that did not stop their study, and they have some promising data. So that may change for inpatients. For outpatients, I think most of us would heavily consider giving the monoclonal antibodies. Obviously, this is where you'd also monitor very closely to see whose contacts of whoever got sick. Are there other vulnerable people in the household? Instruct people about how to protect their loved ones, families, things like that. And also, the other thing is, if someone's acute in disease, I would not give them steroids. So in the early viral shedding phase, monoclonal antibodies would be good. I would not give them steroids. The steroids are helpful in the inflammatory phase, which is sort of the second week. And this is a common mistake that primary care physicians, it becomes very confusing. When do you treat with steroids? We know they're immunosuppressive. At first we were worried. And then data came out that showed that when people are getting the more serious inflammatory complications, steroids work. But in the early phase, when you're initially diagnosed with COVID, you should not use steroids and consider using the monoclonal antibodies. If you're admitted to the hospital, you have problems with your oxygenation and things like that, then we would use an antiviral like remdesivir. We would probably use steroids. If, and as I said, there are no monoclonal antibodies except in some studies. So we might use convalescent plasma depending on our degree of worry. And then now, after sort of some literature that went back and forth, it looks like that people who are in that inflammatory phase and look like they may be about to land in the ICU and things like that, the IL-6 blocker tocilizumab probably would be something that these days we would give. So, it's a pretty complex algorithm of what you would do. But I think right now, if someone were diagnosed with COVID now, I would strongly consider referring for monoclonal antibodies. I wouldn't give steroids. I would monitor very closely oxygenation and things like that. And then there's a different treatment regimen that someone would undergo if they were in the second week of illness and had problems with oxygenation and possibly might need hospitalization.
Very good. Thank you very much. Dr. Lockwood, I would just like to ask from your perspective, what effect has this pandemic had on medical education? It's interesting. I think some of our medical journals and scientists have followed the bad idea of being first rather than getting it right. It's kind of like the public is now seeing the sausage making that goes into medical science and how a lot of things can't be reproduced. But how are you seeing the pandemic effect on your school, your wonderful school, and the students and going forward from here?
Well, yeah, of course, the initial response was to move everything online. And in some ways, we were a little bit luckier because we were the Microsoft Innovation Center. So we had already been experimenting with Microsoft Teams pretty extensively, and lectures were being given by faculty on the main campus to the students downtown already. So that was one advantage we had. Second advantage was that we actually had a number of master's programs that were delivered entirely online. So we actually had a fairly deep bench of folks that knew how to do that. So that conversion took about a week to move the entire curriculum online. And of course, now it's more of a hybrid structure. But what's fascinating is that this generation didn't particularly like coming to school anyways, and they didn't like coming to lectures. So we taped all of our lectures, and they would often watch it on YouTube. So we probably taken a trend that was happening anyways, and accelerated it and made it a better learning platform for them. So that, I think, was a win. Now we've subsequently gone back to hybrid, and on June 28th, we'll be back to regular classes, although all those lectures will be stored anyways. Now, lectures are much less common. When I first got here, we had 40 hours of lectures a week. Now we're down under 15 hours of lectures. So we've moved to a much more active learning that often are required. So the complaint is we have all these required classes. Of course, when I went to medical school, you shut up, you did your job, you sat through the lectures. And if the teacher wanted to smack you, you didn't. In the Billy Budd, Mutiny on the Bounty phase of medical education. So, I think those things have accelerated a trend that was already something millennials were seeking, and probably won't go back to a routine that didn't involve lectures that were available online, in person, or taped. The other thing that I think has changed dramatically is that we found that, frankly, the interview process for medical school and for residency was very efficiently delivered with virtual interviews, and much cheaper. And as I mentioned, that's maybe one of the reasons we're seeing maybe I didn't mention it here, but we definitely have seen a big increase in applications this year of over 1,000 additional students applying.
Wow.
So we've lowered the kinetic energy required for that reaction, and so we're seeing a lot more applicants as a consequence of that. The other thing that I think has been accelerated by COVID is this notion of the rapidity of knowledge accretion. So as the faculty are about to start smiling because they heard this 400,000 times from me, when we were building the new building, I kept saying we have to build a educational environment that that is dynamic, because in 2020 medical knowledge will double every 73 days. And I got that out of some obscure journal. By last year, the AAMC was claiming that it was doubling every month, and with COVID, it was probably every 14 days. I mean, you've just got an example of some of that just in the comments made by my colleagues. So this is an astounding change in the requirements for educational content delivery. When I graduated medical school in 1981, medical knowledge doubled every 20 years. Now it's every 20 days, probably. So it's an entirely different world, and they really are being taught to curate information. They're really being taught in a much more rigorous way to enhance their clinical reasoning skills and their deductive skills. I joke that watching that PBS Sherlock Holmes series is much better preparation for medical school now than reading Harrison's. Well, there's some truth to that. And so, creating this new structure is I think, all been accelerated by COVID. These are trends that were developing anyways. The other thing that I found was that you couldn't get information fast enough, that PubMed was no longer sufficient, UpToDate was no longer sufficient. I have the great misfortune of being the editor of about 200 up-to-date topics. And the COVID topic alone consumes about all the same amount of time as the other 199. So it really is extraordinary. And the The other thing is the information is often contradictory. So you need to be able to discern what's valuable and what isn't, and have that discernment occur at kind of the point of care and point of time you need to take care of patients. So very different world than it was in 1981, but it's a very different world than it was in 2020. So these kids, I don't envy them at all. They seem to be tolerating it very well, I'd say, for whatever reason. But it will be great to have them all back on June 28th, open up our collegia, have the building with, students running amok and yelling at me for whatever reason raison du jour that the food was cold downstairs or whatever it was. I miss all that, but at any rate, I think we've learned a lot from the pandemic, and I think it will enhance education.
It's certainly fast forwarded maybe 10 years of innovation into 1 year. And I think the other thing these students will be dealing with will be artificial intelligence and how that's going to impact them. I will say, I've been hearing that medical, I'm older than you are by far, and I've been hearing that medical knowledge doubling, but I can tell you a lot of the journals and things, most of that, the vast majority of that, as you know, is not reproducible. And, and a lot of it's being paid for by the pharmaceutical industry. So I'm not sure how much knowledge there's there.
Noise is doubling every 20 days.
That I agree with. Dr. Sinnott, would you take a moment and compare the vaccines? 2 or 3 months ago, we were in the beggars can't be choosers category. And now my patients are being very connoisseur of these vaccines. Tell us about the difference between them. And I read an article the other day that said there's 200 other vaccines that are in trial right now. So there's a bunch more in the pipeline. How do you compare them?
Well, I would observe that other people on the panel will know far more about this than I will. In general, the study designs are made so they're not easily compared. In other words, Moderna does not really want to go head to head with Pfizer. So they have different endpoints. Pfizer's endpoints might be admission to the ICU and death, whereas Moderna's endpoints are, do you get sick and do you go to the hospital? So you can't have an ad that Pfizer is 97% effective and Moderna's only 96. This makes interpretation of the data very difficult in head-to-head examination. In general, as a large group, the mRNA vaccines are astonishingly successful beyond anyone's dreams. Pfizer, who has the world's largest pharma company, in looking at about 75 to 80 million people who had completed vaccination, only had about 5,200 patients that were breakthrough events that actually became sick. And as I read this data, of those 5,200, none died and only a few went in the hospital. So these mRNA vaccines are astonishingly successful. We don't know how long they last, but they are very safe. On the more traditional vaccine platforms, they again use different endpoints, so it's hard to compare. I would encourage people that since we don't really have all the data we want, that you should get vaccinated with whatever you can get, and we'll sort it out later. But I would definitely yield this discussion to Drs. Lockwood and Kim.
All right, can we have a comment from each of you?
I completely agree with Dr. Sinnott in that I think it's really remarkable, though, that the vaccine trials, even though they were set up differently, they came up with the same answer, right? Serious disease, death, they work. I think the other disadvantage for the vaccines that came out after the mRNA vaccines is many of them were trialed in regions of the world where the variants were starting to emerge, like the UK and South Africa. So even though those like the AstraZeneca and the Janssen may not have worked quite as well, they were trialed in an environment where, you know, apropos to our earlier discussion, there were variants that were probably a little bit less responsive, you know, or less easy to kill with the antibodies and things like that. So it's really tough to compare them head to head. I agree with Dr. Sinnott. It's amazing as a scientist and a physician to see how well all of these work. And also it's quite reassuring that all of these pharma companies that compete with each other, they got similar results as far as them really working and things like that. So I think you get vaccinated. I think it looks like the response is pretty long-lived, but because these variants are coming, we may now need boosters either because the response wanes or there are new flavors, but you know, we're used to that from influenza. So I think, you know, the vaccines work. And I also think from what Dr. Holt was saying, you know, we're not having serious infection in the older people who were highly compliant with getting vaccines. I think that also is telling us that these work, and then we have to see what happens next.
Very good, thank you. Dr. Lockwood, did you want to?
Only add a couple of things. One is that the vaccines work only if you actually get vaccinated. So we really have to work on adherence and getting the kind of the three big groups that have been recalcitrant and sometimes with legitimate historical reasons to accept the vaccine and get over it, because it really is going to be critical. I think that a couple of additional points. One is, I think John and Kami nailed it, but for example, the J&J vaccine was a 1 dose. So how do you compare that to the 2-dose mRNA vaccines? It was probably, you know, 1 dose probably worked better with the adenoviral vector than the mRNA vaccines, but that wasn't the choice, right? So, you know, it makes an apples to apples comparison almost impossible. And in fact, there's some discussion that you should have a second dose with the J&J vaccine. I think that as an obstetrician, I would just, and I hate to favor one vaccine over another, but I would favor the mRNA vaccines for pregnant women and women planning on pregnancies, just because the pattern of autoimmune thrombotic thrombocytopenia that we see with the adenoviral delivered vaccines is something that's not uncommon in pregnancy. TTP, antiphospholipid antibody syndromes are not rare in pregnant women. And so there's probably something about the hypercoagulable state of women, the fact that women already have increased platelet turnover in pregnancy, and exposure to neoantigens that induce antibody responses, all of which probably would make me favor the mRNA vaccines. You know, I also hear all the time these crazy rumors about infertility. There's absolutely no biological plausibility for any of the vaccines to cause infertility. There's no evidence that they cause infertility. There is clearly greater risk of adverse pregnancy outcome with COVID infections, higher likelihood of being hospitalized, higher likelihood of being ventilated, possibly a higher likelihood of dying, certainly a higher likelihood of premature delivery and babies having cerebral palsy and chronic lung disease, and a higher rate of stillbirth. So, you know, not only does it make no sense to not get the vaccine because you're worried about infertility, but you should be very worried about not getting the vaccine if you're a reproductive age woman or even a pregnant woman. So my advice to pregnant women would be get vaccinated, but if you can, get the mRNA vaccine.
Well, that's great. Listen, our hour is about, I want to thank our panel. You know, what an exciting time for these 5 scientists to be in the middle of a pandemic. Is the analogy I could think of would be storm chasers who've studied tornadoes, and there's a giant tornado or hurricane coming and they're all racing toward the tornado. And you guys, you know, as scientists, you're in the middle of a pandemic, and now we're having vaccines coming out in the middle of a pandemic. That's never happened before. Very exciting times. And the other thing I like about our panel is they're all happy warriors, which is a wonderful way to be. Thank you all for the evening. We've got several more questions, but we promised we'd get it done in an hour. So thank you very much and have a great evening. Take care.
Thank you very much.
Thank you for having us. It's a pleasure.
Thank you.